Thank you for joining us for the Diversity in Healthcare session. My name is Zach West. I'm a first-year pediatric resident at Emory University in Atlanta, Georgia. And today we will examine diversity in medical education, hear about policies that have been advocated for at the institutional level, and discuss how diversity in medicine impacts patients. While many have been advocating for diversity in medicine for years, including our speakers, the combination of recent murders of Black Americans by police, the subsequent protests, and an ongoing pandemic that has disproportionately affected racial and ethnic minority groups has created an opportunity for widespread changes to policy and practice within institutions. The question arises, how can we maintain this momentum and use this powerful energy to move in a positive direction? Medical students are stepping up in big ways to advocate for diversity and anti-racism education in their curriculum and the field of medicine. We will hear from two student leaders today, Naomi Kinsey and Imani Job. We will also hear insights from those who have dedicated significant portions of their careers to researching and improving diversity in healthcare, Dr. Massaquoi, Dr. Bamra, and Dr. Alhadithi. We hope this international conversation will allow us the opportunity to learn from each other and move closer to creating an environment informed by diversity, equity, inclusion, and justice. Special thanks to Emory Medical students Imani Job, Grace Chung, Claire Castellano, and the ICGRx team for helping organize this session. Before we begin the discussion, I would like to briefly run through how the session will work. We have prepared questions on the topics. Each question will be directed to one speaker to begin with, and then we'll open the floor for all speakers to provide their input. After the question has been discussed, we'll move forward with further questions. We're very excited to see what today's discussion will bring. Without further ado, we would like to ask the speakers to introduce themselves, starting with Dr. Bamra. If you could just unmute yourself quickly, Dr. Bamra. Thank you.
So I'm J.S. Bamra. I'm a senior NHS psychiatrist in the UK, and I'm the chairman of the British Association of Physicians of Indian Origin. I'm a trustee of two charities which are very dear to me, the African and Caribbean Mental Health Services, and LMCP charity, which is a charity for South Asians, and a board member of Synergy Collaboration, which seeks to look at mental health inequalities and to correct them. Thank you.
Thank you so much. We're very happy to have you. Dr. Massaquoi.
Hi, good afternoon, everyone. My name is Notisha Massaquoi. I'm a subject matter expert in health equity and anti-Black racism. My work has centered around specifically Black and racialized women, and I'm responsible for the development of the only community health center in Canada that specializes in primary health care for Black and racialized women. I serve as a trustee of the Center for Addiction and Mental Health here in Canada, and I'm overseeing currently the anti-racism advisory panel of the Toronto Police Service, which is the largest police service in Canada. Our responsibility is to ensure that what we call the local inquest recommendations, which address policing, anti-Black racism, and mental health, are implemented. Our final report will be coming out next week, which I'm very excited about. But I can talk more about that in our discussion today.
Thank you so much, and thank you for your dedicated work. Dr. Alhadithi.
Hello, everyone. Thank you very much for inviting me to be here. My name's Nada Alhadithi, and I'm a plastic surgery trainee in my final year. My background is predominantly as a surgeon, but also as a BME woman in a very male-dominated environment. I previously was the clinical lead at the strategy unit in the Department of Health and Social Care, where I worked on data transparency. And I've also worked to support more granular data availability with the Workforce Race Equality Standards with Mala Rao, to make us move from the where is the problem to how can we fix it, and providing more granular data and data transparency. I'm also a co-founder of Women Speakers in Healthcare, and we are representing with my other 4 amazing co-founders to try and ensure there is balanced gender representation for every healthcare event. Thank you.
That's such a great cause. I really appreciate that. And thank you for joining us. Now, Naomi Kinsey, please introduce yourself.
Hi, everyone. My name is Naomi Kinsey. I'm a third-year medical student at the University of Washington in Seattle. So my history with anti-racism work has been, primarily being an African-American or Black woman in the medical system and finding a way to navigate that and navigate medical education. I also was a former student lead for a program called Dr. for a Day, which is the program that works with elementary, middle, and high school students to help them get interested in the medical field and provide them with mentorship. And then additionally, I've been involved in activism at my medical school around changing the way that our curriculum addresses race and racism when teaching to medical students and how that affects our clinical practice. I'm very happy to be here.
Thank you. That's so inspirational to step up as a medical student leader and take charge in connecting where you want the curriculum to go. And now we have another medical student that did a similar thing. Imani Job, can you please introduce yourself?
Hey everyone, my name is Imani Job. I'm a rising third-year medical student with Naomi. I actually went to the University of Michigan, graduated there from 2017, and that was an institution where I was heavily involved with social justice advocacy work. So here at Emory, as the elected class president for the class of 2022, I tried to bring some of my passions and experiences to hopefully advocate for better change for not just my class, but also the entire School of Medicine. And so inspired by the work of Naomi and plenty of other medical students nationwide, I've been working on a proposal, an anti-racism in medicine proposal with 3 of my brilliant colleagues, student doctors Deja Ham, Grace Chung, and Amy Kim, to help advocate for increased curricular changes, focus on race and diversity, and also to help establish a student committee on advocacy for racism, to give students a seat at the table for upcoming changes to diversity within our medical school experience. It's a pleasure and honor to be here amongst all of you. Thank you for allowing me to share my experience as a student.
Thank you so much. We're really happy to have you here as well. So for the first question, I'm going to direct this to Naomi. I want to start with talking about medical education. So, Naomi, where do you see room for improvement with regards to diversity in medical education? And how can medical school programs work with students in addressing necessary changes? What was your experience like advocating for change at your institution?
Yeah, so I think the first step in making change in these institutions is to first kind of move away from the term diversity in medical education. So I think a lot of the times what people actually mean when they say diversity is racial diversity or diversity work. What they really mean is anti-racism work. So I think the first step for these schools is to really adopt more precise language, to be more precise about what exactly we're trying to address and what we're trying to move towards, which is a curriculum that is focused and centered around anti-racism work on health justice and health liberation. So that being said, I think one of the first areas of improvement that we can work on, and one of the more obvious ones, is that we need more students of color in medical school, particularly Black and Indigenous students. This isn't necessarily equality, it's equity. So we can't equally divide resources to people when people are inequally being affected. So equity means making sure that you provide the extra resources to people from communities that have been traditionally and continue to be marginalized so that they can then be at the schools, be in these leadership positions, and in areas where they have the power to make change. I think the second area of improvement that schools need to work on, and particularly that myself, it sounds like other medical students around the country have worked on, was curricular changes. So we need to be able to teach the history of medicine that values the context of why we see racial disparities continuing, and as to be as crucial and valuable in the process of becoming a physician as the pathophysiology that we're being taught.
what do you see for room for improvement in regards to diversity? We'll focus specifically on anti-Black racism in this. And what have you done with your institution and your colleagues to advocate for change?
Absolutely. So I'm going to try to keep this short and sweet because I want to give space to our three wonderful physicians who we're all really eager to hear from. But really quick, areas where I think that there's improvement and that we've tried to advocate for in our proposal is we think that these conversations about anti-racism, specifically within medicine, need to start being longitudinal conversations that students have. So I think a lot of the times institutions are well-intentioned in that they will schedule sporadic lectures here and there to focus on race and bias, but it does not have the same impact as having these conversations be more frequent and span all throughout our medical education career. So in our proposal, we're advocating for students to start engaging in these dialogues before they even enter on campus through a book club. And then we have outlined specific curricular changes from the M1, M2, M3, and M4 years so that hopefully by the time students are about to go out to be residents and take care of patients, they've immersed themselves in these very pertinent and important dialogues that they can then carry with them and translate that into better patient care and more culturally competent patient care as well. And then I also think that on the faculty side of things, there's room for improvement in the sense that we need to be mindful of who it is that are leading these conversations regarding race and diversity. And so we're advocating for faculty to be well-trained in having these conversations because oftentimes what ends up happening is these really important group discussions take place in smaller student processing groups, but students have differing experiences because some faculty are more comfortable and have the tools necessary to be able to carry out these dialogues and engage students, whereas others struggle a little bit more with these issues. And so that's also an area where we see a great need for improvement. Yeah, and so with that, I'll go ahead and give it back to you, Zach.
Great, thank you. Do any of our other panelists have or speakers have any insight into this topic that they'd like to share?
May I?
Yes, please do, Doctor.
So I've done a huge amount of work on discrimination and diversity. And you know, Zach, you mentioned the definition of diversity, and that's the most important thing. And by the way, this is the most important. I know you've had very distinguished people in the whole session, but this is it. This is the most important thing in medicine today, and COVID has exposed a lot of these issues. So you know that diversity is not just about racial discrimination or about gender discrimination, but it's also about sexual orientation, disabilities, religious orientation, all that sort of thing comes within the scope of diversity. And really, I mean, diversity in medical schools has not got that much better, I'm afraid, because there's been a survey that's been conducted by the BMJ, which was published earlier this year. And it looks like for the last 10 years, 40 of our UK medical schools, out of them, only half of them have been collecting diversity data or data on racial discrimination anyway. And of those, there have been only 11 complaints out of 40 medical schools over the last 10 years. So this is a real problem. And discrimination in medicine, I'm afraid, starts right at medical school. It starts right down there and it carries on throughout medicine. And what we need to do is to actually make sure that right from medical school, people are aware that this is discrimination, and also that our medical students are empowered to be able to say, to call it out. I think that has been an issue as well, because many fear that their careers might be interrupted if this happens. UK universities as well don't do particularly well, because over the last 4 years nearly, there have been only 560 complaints, even though 60,000 of them said that they had made a complaint. So we know that the CEO of Equality and Human Rights Commission in the UK has said that universities are oblivious to the issue of racism. And this is an issue that plagues many of the universities, many of the medical schools. And therefore, that is why we have to really try and address this issue. That is why this is the most important thing, because to my mind, because it cuts short brilliant careers because they've been bullied, harassed, or anything like that. And we also need to know that there are four forms of discrimination. So it's not just direct discrimination, which is right in your face and you know it, but it's also indirect discrimination and victimization, bullying and harassment. All of these things come in there, and we need to empower people to be able to call it out.
Thank you, Dr. Obama. We really appreciate that insight. Dr. Massaquoi, did you want to add something?
I do. All of my panelists have said a lot of brilliant things that are necessary. I just want to add that when we're talking about diversity, we also have to talk about disparity and disproportionality when it comes to medical schools. So it's the understanding that what is not being taught and who is not able to access medical school has direct links to the level of health disparities that we're seeing in Black and racialized communities. In Canada, for example, this year, our largest medical school only graduated one Black student. And it was a big issue because when she entered medical school, she was very vocal 4 years ago about being the only Black student in her class. And that sparked a lot of activism and work for those of us who have been fighting for this for years, in terms of myself being one of the few Black CEO and senior health executive leaders in the country, not even being able to hire Black physicians and racialized physicians because they're not graduating, they're not even getting into the medical schools. This year, we will see the largest class of Black medical students entering a medical school at 24. And we also saw the students collectively across the country gathering to form the first Black National Medical Student Association. Those are the things that are happening. But if we don't understand the issues at the level of admissions, in terms of it not being representative of the populations that we're serving here, I speak for Canada specifically, where we make up 8% of the population in terms of Black communities, and we're seeing such low numbers in admissions. A lot of our advocacy and work happens well before people even enter medical school and the poor experiences they're having in medical school. I am happy to say that the young Black woman who raised her voice to say that she was the only Black student in her medical class, we were holding our breaths, because in 4 years, that means we would only have one coming out of our largest school. I'm very happy to say that she graduated and was valedictorian of her class. But there's a lot of work that needs to happen very much upstream before we even get into the medical school system.
Great, thank you so much. Dr. Alhadithi, you recently wrote, and I quote, "There is a lack of diversity in senior leadership roles in the NHS. 41% of the doctors in the NHS are from Black and minority ethnic backgrounds, yet only 17.5% of medical directors and 21% of professors are BME. Only 8% of NHS trust chairs and non-executives are BME. The problem is even worse for female BME NHS staff, where the intersectionality of gender and race is a further impediment to career progression. A gender pay gap of 17% in favor of male doctors over female doctors, as well as the fact that 1 in 12 women in the NHS experience sexual harassment, is unacceptable in a civil society. What specific policies or practices have you seen as effective or ineffective in promoting diversity? How can we move from rhetoric to actual meaningful action?"
I think that's a really good point and a really good challenge, because there's a couple of things that need just to be said. The NHS, although it's one brand, is actually made up of individualized trusts throughout the country, and each trust is able to lend and steer their own local policy, and that makes it very challenging. I know that Simon Stevens and people in NHS England and the RES team are working really hard to try and improve the situation, but actually there still isn't enough being done. And there's huge amounts of unwarranted variation, and there's a huge amount of inequality in access to justice in the NHS. So, for example, I recently conducted a survey which is due to be published of pregnant women in the NHS, 170 women. And of 170, only 13 said they had no problems with workforce structural discrimination while pregnant. And these are systematic and structural barriers to the progression of women. And then that is further compounded, as we know, by, Professor Crenshaw's term she coined of intersectionality, whereby these two different lenses come into being in one space. So as a woman and then as a BME person, you get the compounded effects. So not only as women are you facing structural discrimination, you're also then having to deal with the fact that a lot of your senior leadership team are white, and they're usually white men, and they don't understand the lens in which you have experienced the world, and their eyes glaze over because they've not necessarily seen it as a significant problem until now. And that's one of my main things that I want to bring to the fore in this discussion today, is that obviously the tragedy with George Floyd and the movement and the activism that it has inspired around the world is really important. But actually, historically, and especially I think in the UK, there's an insidious kind of prejudice that just infiltrates our systems and are taken as the sort of typical white male. You see it in medical textbooks, you see it in everything. And therefore the data isn't there on BME people, on women, on trans people, on LGBTQI and on disabled people. And therefore they're treated as other. And actually that can't be the case when 50% of the population are women and when 44% of the workforce are BME. So when we're not other, we have a voice and we should rise up to speak our experiences.
Great, thank you so much. Would anybody else like to add on to that?
I think in terms of the medical education, just following up on what was just said, is that one issue that we're seeing is that we're kind of treating physicians and faculty members as experts on everything. So not only are they experts on the biology, now we're expecting them to be experts on the Black experience, the experience of trans patients, the experience of people with disabilities. And that's just not the case. It's not realistic. And I think in 2020, when we are able to have global conferences like this, where you can bring people from all over the world together and everything can be held remotely, there's no excuse for having faculty that are not content expert materials, that aren't content experts, or that don't have the lived experiences of these communities to be speaking for them and speaking about them, right? You could have lectures where you bring in someone from a different school or even from a different department at your university to come in and give lectures. There's no reason why, because someone is a physician, they are then lauded as an expert on everything else and are expected to teach students. That's how you end up with discussions that aren't very in-depth, discussions with facilitators that aren't comfortable with the material, and then the students take that on and carry that in their practice. So I think that's a concrete change that could be made based on these discussions that we're having.
That's fantastic. And I really think that what it comes down to is we got to stop talking about things in silos and just saying, okay, well, this is going to be our week for, anti-racism curriculum. This is going to be our Black History Month. Like, what Black history is all of our history, And so we have to learn about that and integrate it into our curriculum. So I really appreciate where you're coming from. And I think that it's also really important to learn from expertise in other fields, learn from social workers, learn from nursing, learn from everybody who, be it whether or not they are in healthcare or outside of it. And so I think that that would give us a much better perspective and further this movement a lot. So would anybody else like to add anything before we move on to the next question? Okay. Dr. Massaquoi, this question's for you. You've worked a lot with local officials to improve the collection of demographic data so that we can best identify the health experiences that racialized communities are having and therefore treat this patient population. How is that initiative going and what changes has it prompted? How can we better identify and address the health issues and experiences that racialized communities are having?
Thank you, Zach. So currently in only the province that I'm in Canada, Ontario, we just were successful in getting legislation passed so that all government funded organizations must collect race-based data. So currently in Canada, race-based data is not collected. And for those of us who've been working in healthcare for years, it creates obviously a problem in terms of being able to identify health disparities, particularly Black and racialized communities that are facing. So an organization such as Women's Health and Women's Hands, which I led for many years, we were able to collect race-based data based on our client population, but it was only specific to those people who, Black and racialized women who could access our services. So we've been fighting for many, many years for the collection of race-based data across the entire healthcare system. The legislation was passed with the exception of healthcare. So all government-funded organizations in Ontario must collect race-based data with the exception of healthcare. And the Ministry of Health fought very hard to be excluded from that legislation. So we are still fighting very hard for that. And with the onset of COVID-19 this year, what we saw, and we saw it across the globe, especially UK and the US, the overrepresentation of Black and racialized people in that pandemic. And the same thing was showing up here in Canada. We got a head start by understanding what was happening in the UK and the US and started lobbying very hard. So what we've seen is now a first attempt to collect race-based data for COVID only, but we haven't seen the results. It's been an uphill battle continuously. And because it cuts across every sector where we're experiencing poor outcomes as Black people, we not only fight for the collection of race-based data for healthcare, we've also moved that fight into policing as well. And as of January 1st, through the work that I was doing chairing the Anti-Racism Advisory Panel to Police Services, have fought and was successful in passing the first policy of any police service in the country where the Toronto Police Service must collect race-based data on every interaction that they have with citizens of the city. So it's a long fight. It's one that I know I've been involved in for the past 25 years. What we see in the provision of healthcare are the health disparities, high rates of HIV, high rates of hypertension, all the stress-related illnesses, and I'm sure everyone on this call understands that. But we have no concrete data or evidence to help us actually address it effectively. And also to help us develop curriculum, develop treatment, and all of the things that would come out of having adequate race-based data.
Thank you. Yeah, it's great that that was passed with a police force, and I'm happy that they were going to be collecting that data, but we really do need it in all facets of life, and especially healthcare. Dr. Alhadithi, would you like to add something?
Yes, just to back up that point about greater data transparency and disaggregated data that needs to be put forward. So that's something that we were working on for the RES team, and we're looking at representation in leadership roles, differential attainment across training in the career pathway, ethnicity pay gaps, and a whole other host of sort of more granular data sets that need to be collected, collated, and shared publicly so that they can be cross-examined and the conversations can be had in a meaningful way. So I absolutely agree with that.
Dr. Bamrao, would you like to add to the conversation?
So I think what Nada says is absolutely right. That certainly in the UK there's been a better collection of data at the workplace in the National Health Service. But what you do with it, because the NHS is not one nebulous body, what you do with it is really rather complicated. It's been a journey. 20 years ago, the BMJ reported the case. So race discrimination and all kinds of discrimination is costly to the patient as well as to the NHS and of course to the individual. And a case in point is that 20 years ago, in 2001 actually, the BMJ reports that that a senior surgeon said to a trainee, "You're not operating on bloody Nigerians here, you're operating on a normal human being." Such dehumanizing comments would have passed before, and probably did. In that case, that was taken up by a tribunal, and there was a case made. The surgeon, she was a white person, the surgeon who helped this trainee. Unfortunately, she had to retire at the age of 50, such was the pressure on her. And so the NHS lost a brilliant surgeon as well as having to pay out. So discrimination, we know, also costs patients, both in mental health as well as physical health. The outcomes are worse where there is discrimination against patients, whether that be from their ethnic origin, religious orientation, or whatever it is, or sexual orientation. And that is why this is important, not just for us as doctors and nurses and other professionals. It's very important for the patients because they are the ones ultimately that lose out. Data collection is key. And I'll go back to what I was saying earlier. I think that data collection needs to start at medical schools and universities for all of us, doctors, nurses, pharmacists, all of us, because by the time that we come into the NHS, there are already entrenched attitudes.
That's a good point. I'm reminded of the study that was done of first-year medical students that asked about how Black patients feel pain, and medical students overall thought that Black patients feel less pain and they have thicker skin. And so this is something that's a systemic issue, and we have to address systemically as well, whether that's tearing down the systemic policies that have propagated the racism or just coming together like in conversations like this to move forward. Dr. Alhadithi, do you have something that you wanted to add as well?
Just a quick point to Professor Bamra's point that prevalence of discrimination against the BME staff is one of the strongest predictors of lower scores in multiple indicators of patient satisfaction and quality of care. And I know that from our DHSE data, so absolutely. Thank
you, appreciate that. And now as we move to talking more about patients, I want to wrap up with this last question as we run out of time. Thank you all for coming again. How can we implement policies and procedures to avoid subjecting patients to undue discrimination? And Dr. Massaquoi, I think that you talk a little bit about this, about how coming up with it, how aggregating this data is one of those possible solutions. And I was wondering if you had anything to speak on that.
I'm just going to quickly state that we don't have a level of accountability or any recourse when people experience racism. We don't even have proper reporting mechanisms. And as Professor Bamra noted, the disparity in the reported cases versus what was actually noted by the medical school. So we don't have any kind of system of recourse to address what is actually happening, what are people's experiences, and who's being disciplined and held accountable for those experiences. In a study that we conducted with young Black and racialized women and their experience in the healthcare system across the country, 72% reported extreme levels of racism that they experienced as teenagers in the system. And I won't go through what, I would just say these egregious experiences they had as young racialized and Black women in the system. What ends up happening is that they disengage from healthcare very, very young. So then what I see in healthcare services are Black and racialized women showing up when they already have HIV, when they already have diabetes. They've not engaged with the healthcare system because of the racism that they've experienced so young and the avoidance of wanting to have any of other experiences of that nature. So I will turn to my fellow panelists, but that's the point I really want to drive home. It's about accountability and how do we hold people responsible so that there is some recourse when you have a racist experience in the healthcare system.
Thank you. I really appreciate that. Does anybody else on the panel have anything to add?
Sure. So, on the medical student side, this is something that we've been thinking about as well for the proposal. And some of the solutions that we've come up with that we think would be really effective are having students engage in some sort of implicit bias training. Because I think it can be really helpful to be aware of some of the subconscious biases that you do hold, so that when you do encounter your fellow colleagues, you do encounter your fellow patients, knowing the biases that you have can help you to combat them when you do encounter individuals who hold those identities. And then I also think as a student, sometimes it's really hard to speak up when you're surrounded with your superiors and individuals who are grading you and kind of who hold the key to your educational future. But I think one way to combat that in general is just to have students engage in upstandard training, and also to have faculty engage in upstandard training, so that when these really unfortunate microaggressions do happen, you're able to better combat some of those experiences and digest what could have gone better later on down the road. And then lastly, I think it's important when we're talking about how we can avoid discrimination in patients, that we are putting ourselves in situations where we're able to engage with patients from all different walks of life. So I'm really fortunate at Emory that all Emory medical students are trained at Grady Hospital, which is a fully taxpayer-funded hospital that serves underserved patients and has a predominantly Black population. And I think that that's incredibly important training for students to be able to go through. I'm mindful that not everyone is fortunate to have such experience built in their curriculum during medical education, but I think whenever possible, you should be putting yourselves in situations where you're able to interact with patients from different backgrounds and be able to hear their voice in terms of what it is that they need and how we can better serve them.
I wanted to follow up on that. Oh, sorry.
Go ahead, Naomi.
I wanted to follow up on that perspective from the medical student experience, and also just following up with something that Dr. Baumras said earlier about, trainees feeling like they're being bullied or not able to speak up. And I think one way that this plays into medical school when grading is that we actually are graded on something called professionalism. And there isn't really a set definition of what does it mean for a student to be professional. And in my experience, and I think an experience of a lot of other Black medical students and other minority students, is that the term professionalism is kind of a thinly veiled way to kind of allow racism in grading. So when students speak up about experiences that they've had in lectures or experience that they've had with patient encounters, with faculty encounters, that is deemed as unprofessional. So I think that specifically, that kind of grading is a policy that needs to be more closely looked at and potentially removed. And then additionally, we found at the University of Washington, there was a study done on grading in the clinical phase of medical school, and they found that students of color were actually systematically given lower grades compared to their white students. So this isn't just an issue of faculty undergoing a one-time training or a one-time anti-racism seminar. This is something that is continuous throughout their clinical phase, impacts your career going forward. And we need faculty that are open and willing to make changes in their behavior and changes in their thinking, and are willing to actively engage in ongoing training. And I think that, in a sense, when we ask about how we can make policy changes or procedure changes, as students, we have we have some power, but we're really, we lack the kind of institutional power to really change these policies at the top level. So we need the people that have that kind of power as deans, as administrators, to really be the people that buy into these changes. Until that happens, it's very difficult to see how we can move forward. I think on that note, I think something that's really important for people to consider and become more comfortable with is that sometimes being an ally means relinquishing your power. And in some cases, that means that realizing that maybe people that are not as equipped in these roles to be able to provide support for students of color, for minoritized students, for trans students, for students with disabilities, for students of all different types of backgrounds, and that the most powerful thing that they can do as an ally is to relinquish that power and resign it to someone that is more equipped to do that work. So we don't continue to see these disparities. I think the faster people get used to the idea that being an ally means that you give up a sense of power, that's when change can actually occur. And that's not something that is happening right now. We're seeing changes where we want to change specific words in curriculum, or we want to change specific wording in the grading policies. But as long as you keep having people in power that don't reinforce those policy changes and support them, you're never going to see that change going forward.
Thank you.
You need support and you need recourse.
Thanks so much for that powerful reflection, Naomi. I think you're absolutely right. In the terms we use today in healthcare, what do they actually mean? And are we essentially trying to homogenize things through hiding behind terminology that doesn't always help to improve diversity or provide a proper environment for healthcare students and professionals to flourish? Zach, would you like to say any closing comments?
Yes, I just want to say it's been a privilege to be a part of this conversation. We clearly have a lot of work to do at an institutional level to combat discrimination, and you all have provided fantastic insight and ideas to implement moving forward. I look forward to continuing these discussions and working to implement anti-racism policies in the future, and I implore all the audience members to continue that as well. And then lastly, Dr. Bama brought forward a great quote that I'm going to quote from him. He said, "We cannot change the color of our skin, but we can change our mindset." So I hope we carry that going forward and work for meaningful change. Thank you all so much. We really appreciate it.